So now I would like to introduce Dr. Vincent Singh. He completed his Doctor of Physiology degree at the University of Sydney in 2021. His thesis title was Effectiveness of Compression Sleeve in Preventing Breast Cancer-Related Lymphedema. So that is amazing. He's completed his MS in cancer care with distinction from Oxford Brookes University in the UK. And he has an MS degree in psychology and a bachelor's degree in physiotherapy. He has more than 20 years of experience in cancer rehab and has conducted lymphedema certification programs, being an organizing secretary for the cancer rehab workshops multiple times, the scientific committee member of the rehab conference, and taught in the oncology physiotherapy program at Tata Memorial Hospital in Mumbai, India. So, Dr. Vincent, I believe you're on mute.
Yeah, thank you, Linda. I'm sorry. Thank you, Linda, for that kind introduction. And so it's early morning. So good morning, everyone from Sydney. And I would like to share my screen, and I hope I share the right screen. Okay, so here we are, and I thank the entire Sigvaris team for giving me this opportunity, and also I thank Linda for that wonderful overview of lymphedema, and hopefully the attendees can now understand what I'm going to talk. So, so today I'm going to talk about the two different approaches that are used to prevent chronic lymphedema. That is the prospective surveillance method and a prophylactic approach. So a quick introduction about the condition. I would not take much time because Linda has spoken well. And so arm swelling is common following axillary lymph node dissection. And if once established, reversing this condition is a challenge. Hence, it is important to prevent arm swelling to avoid chronic lymphedema and associated tissue changes, poor quality of life. And there are some evidence to support the prophylactic approach, and we have a lot of studies have been done on a prospective surveillance method. So what we are going to do today is just look at these two approaches to prevent arm swelling. So two approaches, prospective surveillance. So prospective surveillance is to detect arm swelling at a subclinical stage and intervene early usually with compression sleeves. And whereas the other side, the prophylactic approach is to give compression immediately following breast cancer surgery so that we can avoid arm swelling in women who are at high risk. So let us look at prospective surveillance. So instead of looking at individual studies, I would like to take you through a relatively recent systematic review and meta-analysis conducted by RAFN. And this systematic review was to critically evaluate the studies done on prospective surveillance for breast cancer-related arm lymphedema. So the objective of this systematic review was to offer a critical evaluation of the literature on prospective surveillance and early management for lymphedema. And the reviewers were, planning to answer these two review questions. Does participation in prospective surveillance and early management reduce the risk of developing chronic edema? If so, which patients should be assessed and which assessment methods, frequency, and length of follow-up should be used so that it is effective to prevent chronic arm swelling. So let's look at the method the reviewers used. They prospectively registered the systematic review with Prospero database, and they systematically searched Medline, Embase, Cinal, and Central, as well as the Web of Science databases from the inception till 2021. And two independent reviewers screened and extracted data and also evaluated the risk of bias within the studies. Studies reporting lymphedema incidence, prevalence, or severity following prospective surveillance and early intervention were included irrespective of their study design. So they have included randomized control trials, prospective, retrospective studies, because this is an evolving field. And also they included different cancer types and surgery. Overall, they included 24 studies, and as you can see on the right-hand side of the screen, you can see the flow of the studies within this systematic review. And they initially got around 7,000 studies from the systematic search, and they screened only 2,000 studies because many of them were duplicates. And out of that 2,000 studies, 137 studies were screened for their full text, and they included 24 papers or articles reporting 23 studies. And they also did meta-analysis, subgroup, and sensitivity analysis to see the effectiveness of the prospective surveillance model. So let's look at the results. And as you can see, the included studies varied in many aspects. And you can see the pie chart, as the pie chart shows that most of the studies were prospective or retrospective observational studies, and they had only 4 randomized controlled trials. And out of these 4 randomized controlled trials, 2 just compared 2 different prospective surveillance methods, whereas only 2 of that 4 randomized controlled trials really evaluated the effectiveness of prospective surveillance model over usual care. And 1 study was case control study. And that study was done by Stott et al. And that was the first study to look at prospective surveillance model. And now there are many studies reporting the prospective surveillance model. And also you can see that most of the studies are to look at the prevention of breast cancer related lymphedema in arm. And 1 study looked at the breast edema prevention, and 1 study was about the lower extremity lymphedema. And nearly 8 studies were done on exclusively axillary lymph node dissection. As you all know, axillary lymph node dissection is a high risk factor. And additionally, 6 studies reported a subgroup of axillary lymph node dissection, although they included other lymph node dissection also in their studies. And nearly 18 studies reported preoperative measurements, and also they did at least 3 post-op measures within the first year with a regular interval. And 12 studies out of this 23 studies reported more than 1 year follow-up, and length of follow-up ranged between 12 months to 5 years. Again, this is a repeated feature. The included studies used a variety of different measures that to detect the early lymphedema or the subclinical lymphedema. As you can see here, nearly 8 different methods and 25 different strategies or the thresholds they have used to detect early lymphedema. And again, for defining the chronic lymphedema, again, the included studies used nearly 5 different methods and 16 different thresholds. This is a common issue among all lymphedema studies, that we are using multiple different strategies and multiple different methods to measure lymphedema. And the common device that is used to detect early lymphedema or subclinical lymphedema was a bioimpedance spectroscopy. And most of the studies, nearly 81 studies, used compression sleeves as the early intervention method. However, the included studies did not report the type of compression sleeves, whether it was circular knit or flat knit, and also they didn't report about the level of compression. And very few studies reported the level of compression. They have used class 2 compression. And 65% of the studies did not report the length of the intervention or the duration. And those who reported, they used for 4 to 6 weeks of compression for the early intervention method. So let's look at the risk of bias within the studies. And as you can see, the quality of the randomized control trials was not very good, and the overall risk of bias was high. And in observational studies, the observational studies were blocked by selection bias, measurement bias, and also confounders. So in overall, the available literature is not of very high quality. Although I have my own reservations about pooling the data because of the heterogeneity among the studies, because they have used different method to measure and different thresholds to detect arm lymphedema. The reviewers have done a pooling of study in a forest plot, and as you can see, this is the line of no significance, and the relative risk was 0.31. That means there was a low risk in people, those who are in the surveillance method and received early intervention. And although the overall relative risk did not touch the line of no significance, and because of the wide confidence interval and heterogeneity among the studies, and also the small sample size, it was just 134 patients. So we need to interpret this result with a caution. And this forest plot shows the prospective studies or the prospective surveillance method used in prospective observational studies. And here, you can see the percentage of patients with chronic lymphedema. And as you can see, the lymphedema ranged between 0 to 33% within these studies. However, the overall percentage was very low. That was only 6%. So from the prospective studies, you can see that there is that is evidence to support the use of prospective surveillance method. However, you can clearly see that only 2 prospective observational studies was the original prospective observational studies, and others are from the randomized controlled trials. Okay. So to summarize the evidence of supporting prospective surveillance method, as we can see that prospective surveillance may reduce the chronic breast cancer related lymphedema. And this systematic review did search up to 2021, and a few other studies have been published after 2021, and all of them have shown that there is reduction in chronic breast cancer related lymphedema, at least 15%. And however, we need high quality studies. As we can see from this systematic review, the included studies evidence the risk of bias was very high. And bioimpedance spectroscopy is the most frequently used method to detect early lymphedema. And we need urgently agreement in the standard of measure, as well as the threshold to detect early as well as chronic breast cancer related lymphedema is needed. And compression sleeves is the most common early intervention method used in most of the studies. However, we need to know about the type of compression, the compression pressure, and also about the length of compression sleeves to be worn to be effective to prevent chronic lymphedema in the early phase. And of course, the prospective surveillance method is resource intensive because we need to have trained people in lymphedema, as well as we need to have bioimpedance device if you are using bioimpedance device, and also patients needs to follow up regularly, and they have to reach to the center where these measures are available. And how feasible this method or this model of prospective surveillance in low resource setting, which is very, very questionable. And as some of the studies done in UK by Bundred, as well as some studies done in Australia by Stevenson, shown that those who are living in rural communities, they often miss their appointments for these and they report with a chronic edema later on. So that leads us to the next method, that is the prophylactic use of compression. So as I explained before, prophylactic use of compression is giving compression sleeves irrespective of whether they have early edema or not, immediately following the surgery to women, those who are at high risk. For example, axillary lymph node dissection, those who have undergone axillary lymph node dissection. There is a study by Ocholak et al. The preliminary data suggests that prophylactic use of compression sleeves can reduce arm swelling. However, these needs to be confirmed. So we conducted a randomized controlled trial that showed that prophylactic use of compression sleeves reduces the incidence of arm swelling in women at high risk of breast cancer related lymphedema. We are going to look at the results and the study in coming slides. So the aim of our study was to determine whether the prophylactic use of compression sleeves reduces the incidence of arm swelling in the first year following breast cancer surgery. So we conducted a single-blinded parallel group randomized control trial at Tata Memorial Cancer Center, Mumbai, India from 2017 to 2020. And we got prospectively the ethics clearance, as well as we registered the trial. We screened nearly 900 women for eligibility, and you can see the eligibility criteria here. And women, those who were 18 years of age or older and posted for breast cancer surgery were considered. And patients were included, participants were included if they were assessed using bioimpedance spectroscopy and found to be without any arm swelling at baseline, able to read, write in English, Hindi, Marathi, and Bengali, and also able to wear compression sleeves independently. After their breast cancer surgery, we screened for their lymph node dissection status, and if they had undergone axillary lymph node dissection, then they were retained in the study. So we included 307 women in this particular randomized control trial. So at baseline, that was immediately before their breast cancer surgery, we collected their demographic data, anthropometric and medical history data. And we conducted physical examination. As part of the physical examination, we measured their arm circumferences, and also we conducted bioimpedance spectroscopy measurements. Participants also were asked to fill the quality of life questionnaires, the URTC QLQ C30 and BR23. So the following their surgery, and if they had undergone axillary lymph node dissection, then they were stratified using body mass index and as well as preoperative taxane-based chemotherapy status. And a person who was not part of the study then randomly allocated these participants using computer-generated random number placed in a sequentially numbered opaque envelope. All participants attended group therapy sessions and they received exercise, skin, arm, and brain care related instructions. And also they were provided with written information materials. And so we had 307 participants initially, and they were allocated into two groups, that is compression group and control group. So all participants from both groups received the post-operative group therapy session. And participants, those who were in the compression group, received a pair of compression sleeves that was Sigvaris advanced arm sleeve with a compression pressure of 20 to 25 mm Hg. And the participants, those who were in the compression group, asked to wear the compression sleeve from first post-operative day until 3 months after completion of their adjuvant chemotherapy and radiotherapy. And they wore the compression sleeve up to 8 hours a day. And some of them wore more than 8 hours a day, but minimum they were supposed to wear 8 hours of the day. And all participants were reassessed at suture removal the 6 month and 1 year following surgery. In addition, the participants in this randomized control trial were trained to take the arm circumference measures at home and also to record symptoms and sign, that is the pitting test, every month. And they sent these data every month electronically, and one person from the study team screened these data, and if they found any increase or concern in the arm circumference or the arm symptoms, then they advised the participants to attend the department for further evaluation and management. So we also provided the participants with a compliance diary, and in this compliance diary, they recorded how many hours they wore the compression sleeves every day. And if they did not wear the compression sleeves for at least 8 hours a day, then they recorded why they couldn't wear the compression sleeves in this column. So the primary outcome of this randomized control trial was the incidence of arm swelling determined by impedance ratio based on the normative threshold, that is the BIS ratio more than or equal to 2 standard deviation. And we had two other secondary outcomes, and the incidence of arm swelling determined from arm circumference using relative arm volume increase of more than or equal to 10%. And also we included the documentation of the first minimally important clinical difference in quality of life subscales, that is general health, physical functioning, breast symptom, and arm symptom domains. We also was supposed to do the feasibility and acceptability of the compression garment from the data of the diaries. However, during the COVID, we couldn't collect the compliance diary because these diaries were physically provided, and it will be collected in the 5 years analysis. So this is the flows chart. As you can see, we included 552 participants from the compression group and for 149 participants from the control group in the final analysis. So 3 from each group dropped out of the study. They didn't have any follow-up visits after the baseline assessment. And we used time to event analysis, otherwise known as survival curve analysis, for our final data analysis. And that were used to analyze all our primary and secondary outcome. And the patient and as well as study related characteristics were analyzed to use descriptive statistics. So let us move on to the results now. And this is the participant and treatment related characteristics table. And you can see that compression and control group were well balanced in all the factors, especially in the high risk factors such as body mass index and type of surgery, and also the number of nodes removed. And this slide shows the survival curve analysis, or the Kaplan-Meier curve analysis, based on bioimpedance spectroscopy more than or equal to 2 standard deviation threshold. And those who are not aware of the survival curve analysis, I would like to just explain briefly. And as you can see at the x-axis, time since the surgery plotted in months. And in the y-axis, you can see arm swelling free probability. So in the beginning, both group at 1, that means there is no arm swelling. And as you detect one arm swelling, the graph drops. And if there are many arm swelling, then the graph drops drastically. And you can see here, the compression group is blue line and control group is red line. And in the control group, there were many arm swelling event early on. So the graph dropped drastically. And you can see there is a clear difference between the compression and control group throughout the 1-year follow-up period. That means there was more number of participants had arm swelling in the control group. That was evident in the log rank test. As you can see, there was 10% reduction in the arm swelling event in compression group. And we also did Cox regression analysis. And here the hazard ratio was 0.61. Again, for your information, if hazard ratio of 1 means there is no difference between both groups, and hazard ratio 0.61, that is less than 1, means there was less arm swelling in the compression group. So we also analyzed the data with relative arm volume increase more than or equal to 10% increase from baseline. And as you can see, the results were similar to the previous slide, and there was clear difference between compression and control group. And also in log rank test, you can see there was less 10%, more than 10% reduction in the compression group. And also hazard ratio was nearly half in the compression group. So that means less arm swelling was reported in compression group than the control group. What was the main difference between this slide and the previous slide? The overall number of incidents in arm swelling is low in this slide, because this was used the relative arm volume increase, which is more conservative threshold than the previous BIS-based threshold. So this table shows the quality of life analysis, the subscale analysis, and you can see here is the hazard ratio being presented. And you can see that in this slide, none of this subscales were statistically significant different between the groups. So both groups were similar, to our surprise, because we initially thought that providing the prophylactic compression sleeve in a place such as in India, where a hot and humid climate, participants may have a reduction in the quality of life. That's what we thought, but there was no difference between both groups. So to conclude, the prophylactic use of compression sleeves reduced the incidence of arm swelling, delayed the occurrence of arm swelling, and it did not negatively affect the quality of life, physical function, and breast or arm symptoms. So this study also was published in Journal of Clinical Oncology, and this is adequately powered study and used concealed allocation, and also groups were comparable at baseline as we had seen on that table, and longer term follow-up would add more value to this study. And as you can see here, this study, when it got published, it immediately attracted a lot of attention, and it got 112 in the altmetric score, and it is placed in the top 5 research output on that journal. So some women developed arm swelling even with prophylactic compression sleeve. So what we propose is using prophylactic compression and also do self-surveillance. And patients can use the arm circumference measures or arm symptoms record, and also pinching test, as one of our colleagues showed that pinching test reliably shows early arm swelling. So in low resource setting, it would be advisable that using prophylactic compression in all women, those who are undergoing axillary lymph node dissection, and also perform self-surveillance method. And there is again a large PREVENT trial conducted by RAFN in Netherlands to look at the self-surveillance over prophylactic surveillance model. I would like to acknowledge Sigvaris for providing the compression sleeves used in this trial as a grant. However, Sigvaris had no input into the design, execution, or reporting of this study. And I would like to also extend my thanks to all my co-authors and people who helped conduct this study. So I would like to take any questions now, and if you have any questions later on, please contact me through email. Thank you.
The mic is yours, Bethany, my dearest co-moderator.
Thank you. Thank you. Before we start the discussion, though, may we have the poll question, please? Okay, our second poll question: would you recommend using the compression garment for the patient with breast cancer, and when? There's a single choice. Yes, only when there are symptoms before surgical intervention. Yes, yes, once the patient is diagnosed with breast cancer before surgical intervention, and yes, but only surgical intervention, or no, I don't recommend using unless the patient has developed edema or swelling. So please make your choice. We will see the results afterwards. And now I'd like to open up our panelists, starting with Miss Tracy Green.
Thanks, Bethany. An absolutely fantastic presentation again, Vincent. That was absolutely really interesting, and I've just got a couple of things really that were running through my mind as you were talking through your presentation. First of all, when you were looking at physical functioning of the patient, and obviously that was during the wearing of the sleeve prophylactically or not wearing a sleeve. Prior to that, had you actually considered what their general activity levels were like? So were they maybe doing sort of quite hard active work, or maybe a much lighter, depending on the job role that they had? And might that have had a bit of an impact on the results? Or is it maybe something you might be looking at later on?
So yeah, Thank you. Thank you for this wonderful question, Tracy. And it is a challenge actually to wear compression sleeves. And most of our participants were housewives or they were managing their household activities. And as you can see, most of our Indian women, they use their arm for all cooking, cleaning vessels. So they often wet their hand, and so it is a bit challenge in this particular population, and we would really, I personally think that would have affected the results. You know, what I would expect is less number of hours they might have worn the compression sleeve rather than more number of hours, and still the study was positive and we could see there was a reduction. And one of the factors that motivated more of our participants to wear compression sleeves is that they always see these some of the women with chronic swelling roaming around with large bandage, because this hospital is a tertiary cancer center with 70,000 new cancer cases reported every year. We operate around 4,500 breast cancer surgeries in a year, and they could see these women with compression bandages and sleeves, and they really, worried, and they were very enthusiastic in participating in the study. That's how we could recruit 307 participants in 1 year. That's less than 1 year, 8 months we recruited, and we had only 5 refuse to participate because they wanted to have compression anyway, and we couldn't do that in a randomized control trial.
Yeah. Thank you. I think that was my answer to my question. Thank you.
Okay. And I'll invite any of the other panelists to comment or provide any kind of feedback. Okay. And we will then discuss the poll results. The correct answer was yes, or I'm sorry, the 43% of you answered yes once the patient is diagnosed with breast cancer before surgical intervention.
Yeah, it shows the variation to this question. Some doctors, 14% doesn't believe in compression, which is fact on the ground. And it shows here the second question, which have the second answer, which have 43%, that a lot of doctors believe in pre-operative stocking arm sleeve to patient before surgery. And I think this is the same with the conclusion of Vincent from his study, which again, I would like him to elaborate from his study, because he have 1 year follow-up, I think. So hopefully we'll wait for the 5-year follow-up with his amazing. Number one, we need a standardization of how we report regarding lymphedema. You did show from your RCT overview that there is a lot of deficiency and a lot of missing standardization. Secondly, you did mention the preoperative sleeve seemed to offer an advantage. Do you like to elaborate on this, Vincent?
Yeah. So the first point is we need urgently at least agreement about which modality we need to use and what would be the best threshold. And there are some effort going on in this space. So there are groups, they are trying to achieve core outcome sets for lymphedema. And if that happens, then probably we will have a standardized way of reporting the lymphedema incidence in all, at least in research studies. And right now, that since we don't have any gold standard method, the recommendation is what device or modality you have, and use it consistently, and use a particular threshold consistently rather than trying to introduce different methods. And in clinic, we always use our clinical examination and judgment along with these objective measures. We don't just go by any single threshold or a particular number to decide our intervention. So probably Linda would be able to elaborate more. We always use our clinical knowledge, and also there are variations among women. Some women comes to our clinic with a small volume difference, but a fibrotic arm. That lady needs more attention than a person with edema, a large volume, but there is no fibrosis, and which can easily be managed with compression, and they would respond quite well. So there is a clear difference on ground. However, we need standardization urgently. Otherwise, we will be always having this trouble in understanding and interpreting our results. As that's what we can see even in the systematic review that was talking about prospective surveillance method. About compression, I would recommend for high-risk women, not to all of them. So anyone in the audience, please don't misunderstand that, you no need to give compression for women, those who are undergoing just a sentinel lymph node biopsy, or just two lymph nodes removal. And they are at risk, but they are at very, very low risk. And what is more important is education about arm care, skin care, the symptoms, and be vigilant, and also to do self-surveillance in that particular cohort. Those who are at high risk, of course, they are benefited using compression sleeve along with a self-surveillance method. That's what I would like to convey as my results. Thank you.
Thank you. And next, we will go over some of the poll questions that have come in for you. I'm going to combine two of them here. How did you measure the arm volume? And what was the percentage of women who still developed increased swelling in the study?
Yeah, so arm volume is, we used the circumference method, and we also used the truncated cone formula to calculate the volume. And anyone can have a circumference measure, a tape measure, and if you follow a standard protocol to measure arm circumference, then you can have a reliable arm volume calculation. And in our study, we screened their every month result, as well as whenever they came for follow-up. Whenever they hit the threshold of 6.5 LDEX or 2 standard deviation, if you are using R0 value, then they were immediately referred for a compression. So whether they are in control group or in a compression group, they are referred to a lymphedema therapist, and they decided based on the comprehensive assessment what treatment they would be undergoing. So that is the main reason many of the, even in control group, they received compression as those who are in a compression group. And so that's how we had the aim of no one should be prevented from receiving immediate lymphedema management in our group.
Okay, thank you. Did the results of your trial influence the current practice at your institution by means of providing prophylactic compression to every patient?
Yeah, in our institution, yes, of course. Those who are undergoing axillary lymph node dissection as part of the surgery, they receive compression sleeves. And all of them attend the post-operative group therapy session in our center the very next day. And if they are they have undergone a lymph node dissection, axillary lymph node dissection, that is complete clearance, then they would receive compression sleep. However, this study is a good first step internationally. However, we need to have other groups to validate these results. And I would expect some of the developed countries, then we can see the differences or commonality in the study results. That would really then address the practice change internationally.
Perfect. And can you expand a little bit on I'm sorry, I might not get it correct, the paclitaxel drugs coded therapy, and then explain how chemotherapy drugs like taxane and that other drugs can improve venous and lymph vessels flow, so decrease lymphedema together with management of post-operative metastases.
Okay, so again, I'm just skipping the post-operative metastasis for now. And about taxanes, and especially paclitaxel, is shown to be a risk factor in women, those who are undergoing axillary lymph node dissection. So paclitaxel on its own is not a risk factor. It may elevate some amount of extracellular fluid in any person who is receiving paclitaxel, but it is a risk factor for lymphedema in only those who are undergoing axillary lymph node dissection. In sentinel lymph node dissection, its effect is very, very low, very, very minimal. So if they are, that is also for adjuvant chemotherapy and neoadjuvant setting. Receiving paclitaxel can play havoc in the lymphatic system. But even in those women, if they have undergone axillary lymph node dissection, then their risk can increase.
Okay, thank you very much for that. Does not look like we have any other questions at this time. So I will turn it over to Dr. Omar.
Okay, thank you very much. Is something that I have noticed. We started by around 100 attendee, and they all kept across our discussion, 100 over the platform and another 100 over the Facebook, which means that definitely this topic have a deep interest to a lot of doctors. We know that in United Kingdom, 1 in 9 will have breast cancer, and in UK, I learned today from Linda that this is 1 in 8. So definitely these patients are there. We know that 30 to 40% of them post-operative will have lymphedema in their limb. It affects the quality of life quite a lot. And I hope with this webinar, we have summarized really exquisite expertise from Professor Linda, Professor Vincent. They have worked a lot in this problem, and they have really got us the beauty of the clinical expertise in a nutshell. I hope to finish this great webinar with a 1-minute lesson to take home from all our my dearest co-moderator, which is involved in that field in the United States. She's very well known in the United States, and she's done a lot of effort. And our 2 dearest speaker and my dearest panelist, Tracy. So we'll start by my dearest co-moderator to take home message that she had learned from the webinar, and we move to our dearest 2 speaker, and then we'll go to Tracy.
Thank you. Thank you all so much for being on this webinar. It's always great to discuss what we could consider a hot topic, but there's obviously a lot of room for advancing and additional knowledge and hearing different perspectives. So I think it is great to see the continued work on compression for before, during, and after, and as well as all the work that you've done, Linda. It was great to just learn everything you had to present today. So I'm really looking forward to hearing more as things progress. So thank you. I'll turn it over to Tracy now.
Yeah.
Thank you, Bethany. Yeah, I think I would like to echo a lot of your words. I do think that we need to be thinking prophylactically about how we can prevent patients developing that extensive lymphedema if we can catch it early. If we can prevent it, then we are going to reduce a lot of problems for patients in the future. But both presentations were absolutely fantastic, giving much food for thought. So thank you.
Excellent. And Linda, if you like to give us in a couple of minutes your take-home message to all the 200 clinicians listening to you.
Yes, one of the things that I will tell my patients, because as we know, once our breast cancer patients have treatment, many of them are concerned about getting lymphedema. So a couple of things that I will tell my patients is, number one, most women do not get lymphedema post breast cancer surgery. So that I don't want them to get a false sense of security with that, but it kind of goes back to what Dr. Vincent said with regards to the good education and letting them know what are some of the signs and symptoms of lymphedema. The other thing that I say to my patients is to swell is normal, to stay swollen is not. And so there's the difference between edema fluctuation that occurs because it's hot outside, or you had popcorn and beer when you watch the football game, and you come back in the house and your hemodynamic structures work and the swelling goes back down again. So I think what I would like to leave the message to clinicians is, and this is no offense at all to you, Dr. Vincent, because I recognize your paper was specific to volume, which I think is very, very important because we need a measure. But I really encourage my patients not to obsess as much on the size of their limb because that's going to fluctuate. We pay a lot of attention to the texture of the limb. How does your limb feel? Because the size is going to vary with all these external variables that we've mentioned. The texture is really telling us the health of the limb. And if the limb is thicker, there's more protein. As we go back to one of the first slides, protein's hydrophilic, it draws water to it, so therefore there's more edema. So take home message, don't obsess on your measurements, pay attention, and pay attention to the tissue texture of your limb.
Excellent. Thank you very much. Let us take the last comment from Vincent, and thank you very much for sharing your great work in this time in Australia, which is very late in the evening. Thank you very much, and please for you to give us the take-home message, Vincent.
Yeah. So yeah, it is wonderful to see so many participants keenly, watching this space, and I would like to tell you all that good education is the paramount in this space. So please make sure you are updated, and also you give your knowledge to your patients. Take a good proper first session where you can give all the information possible to your patients, because this is the age of misinformation rather than information. Information is gone now. It is the age of misinformation, and they can get misinformed quite quickly than informed. So it is very important to educate them about lymphedema and its symptoms and available treatment and what not to do. Is very important. So I will leave it at that today. Thank you.